And this appointment was set a long time ago.
Yeah, I don't
It
know.
wasn't like a new appointment. It was one we established.
Back in
So,
September or something, I think. Yeah.
yeah, that's unfortunate.
It was on my calendar, so I don't know if it only shows up internally on our calendars. And
It might. Yeah, I don't know.
Yeah, there seemed to be some, this isn't the first meeting we're talking about with this, Emma. So I think there's some disconnect with some external sharing. That's unfortunate.
If I were
sorry
you,
to-
I'd just blame Prism. It's probably Prism's
That
fault.
is right where my mind went. Yeah, so we have, or unwinding. It's either Prism or unwinding. Yeah. All right. Well, it is lower attendance than we've had at past meetings, but I think we can go ahead and conduct business today. And we'll go ahead and kick it off. So if you are a designated representative for this working group, and there are 16 individuals. So if you are representing, or if you're standing in lieu of the individual who normally represents, or if you are representing yourself as one of the designated individuals, would you please just put your name into the chat so that we have a record of attendance for our minutes, please. And I appreciate you all joining. It has been some time. Last meeting was in September, as Emma mentioned. So it's nice to reconvene on this. We had sent out some documents earlier, so I'm hoping that you may have seen some materials we sent out to you. If you are a designated working group member, we had sent some things out to you a few weeks ago, maybe 2 weeks ago, but we'll loop back on that after we go through the minutes and the approval of the minutes. So,
Jen, do you want us to message all of the invitees and let them know the meeting is occurring, and maybe they'll see an email to that effect?
Sharon should have sent one to the invitees earlier today. So she's coordinating this meeting, Becky, and she should be emailing the recipients and hopefully also connecting with them regarding the survey completion and things. So Thank you. Thanks for that. Okay. So the first thing we'd like to do is just get a vote for approval of the meeting minutes. So a motion on that. If we could, please, if you've had a chance to look at the minutes that were sent out. If we could have, once you have had a chance to look at them, if we could take a motion for approving them or any changes.
Jen, this is Russ. I will motion to approve the minutes.
Yep. Thanks, Russ. Do we have a second?
This is Brian. I can second.
Thanks, Brian. All in favor?
Aye. Aye.
Okay, thank you. Any opposed? Okay, great. So thank you. That motion passes for the meeting minutes from our September 22nd event. So thank you for that. So let's move into item 2 and just dive right into the material. So as we've been meeting now for the past year and a half, we have been also subsequently meeting in breakout groups and taking a lot of this work that had been outlined in HB 413 into our UMIC meetings. One of the things that we would like to propose is that we would close up the work that has been directed at this working group. And with this, we have had numerous discussions about the various items that were called out in the bill language. We have also kept pretty comprehensive notes over the course of the last year and a half as we've had our meetings and have a good summary of data. A step towards completing the work as it was directed through HB 413 was to get feedback from the working group members on those specific items. And in an intent to do that, we actually had sent a survey to each of the working group members. And I know there are some people who may have responded to that, which was fine, who may not be part of the working group. But we had sent an email out about 3 weeks ago with the idea that you, and there was an email that was sent by Sharon Stegerwald with an accompanying Google form. And on the Google form, we had broken down a survey for you to provide any final thoughts or feedback on each of the elements as outlined in HB 413. And there were distinct categories of questions and things that were asked. What we were looking to do at this point was to request any additional feedback or thoughts, recommendations from the assigned working group members that we could then put together in a summary document and include, of course, with our notes, and then share them with the working group and have a final discussion on them. When we did send these out, the survey out, we actually heard back from a handful of individuals, but only 3 out of 16 of the assigned working group members actually did respond to the survey when it was delivered. And with that, we actually did send a follow-up email or two trying to get a response. But we really would like to ensure that if there are final thoughts or feedback that you would like to provide regarding each of these elements, that you have an opportunity to do so. Like I said, our intent is to close up the work of this group. We feel like we have active working sessions where we're kind of working towards the aims of this, and that we would like to make a recommendation in this legislative session to have this working group close. So with that, we'll take any questions on that regarding the survey, regarding the questions in the survey, or how we could get your feedback. But one piece is that we haven't had enough feedback yet. So we'd like to, A, do a call out to get your feedback if you have any additional things you'd like to share. And B, if there are any questions, we could take those at this time as well.
So Jen, are you okay if folks just fill out the survey and still send it to you?
Absolutely. Yeah. So we had thought we would get, our hope was to get a response that we could bring it back. We may have one more meeting where we could summarize the feedback from the group and then review it together and kind of highlight common areas. There's a lot of, maybe different ways of saying things, but our goal was to synthesize this into kind of a summary report based off of these, 8 or 10 areas that were called out, and then have those final recommendations together in a summary document. It would be out to you before the adequate time for review before the meeting, and then have a final discussion. So I think that's what we would like to communicate now.
Do we feel like we have recommendations? I mean, I've sat through most of these meetings, and I think there is the notes that the state has been keeping. Actually, I think that's a really good summary of recommendations. You know, so maybe it would be helpful just to bring those up and see if the group has anything else to add, or I don't know, what does the rest of the group think?
I guess I'm okay, either direction. I would love to, see the survey results once there's more representation in there.
Okay.
I mean, I guess I assume when I think about the notes, from previous meetings, I think there was a series of minutes from 2 meetings ago that summarized the department's, for lack of a better term, summary of where we are as a work group. And so to me, those meetings were kind of representative of where things had gravitated towards.
Right.
That's what I was referring to as well, that summary. So
Yeah, and we'll collect all our notes and share those in summary as well. That was the intent, not to just use this one last feedback session as the final standing recommendations, but use the body of work that's kind of been done. Now, much of our discussions, I mean, we believe it's been a positive experience for the efforts that were put forth here. We've made progress, and I think that's like to the next step of where we want to go is to really walk through, and I'd like to even have Becky reflect on some of the work that's been done because of this working group and the positive steps we've made towards ongoing dialogue, problem solving, developing more solutioning around payments and things like that, including some of the updates that are coming in the future. Looking at credentialing processes, we're still discussing utilization management procedures and where we're going to land with that. But those were all things that were on the table when we started. And I think over the course of this discussion, we've made some very positive headway in achieving the goals that were laid out for us here. Now, I know ultimately the goal here was a recommendation on what to do with the TAM population, and it took us back to working on our UMIC contracts and our UMIC model and moving from the payer integration to some more clinical integration, and steps are moving forward in that capacity, which is, we think, very positive and moves towards our overall goals of more integration of the physical and behavioral health programs. We know there's always going to be continued work in this way, but we've really appreciated the dialogue and partnership of the different representatives here in even moving this forward in the time that we've had. So maybe I'll pause there for a moment, and Becky, if you'd like to share, and then have others chime in, because I do think as we look at what our report out will be in these various areas, I think we have to acknowledge the milestones we've accomplished that are moving us towards the direction around looking at what an integrated model for the TAM population will be. So just Becky, if you could summarize some of the work, I think that would be helpful, and then we can have others chime in as well.
Sure. So as you mentioned, one of the primary things that we've worked on is claims management. Providers had expressed some concerns about how claims processing was going, and we have worked with both the providers and plans on that. We did a survey of the plans, a 3-month survey of claims processing, and their report back to us was that claims processing was in fact in line with the department's expectations. As we reviewed the data, they were meeting the expectations for the percentage of claims paid out each month. So we didn't have any concerns about the plans not meeting those expectations. That being said, the plans did take initiative. I think all 4 of them have taken initiative to have better pathways for the providers to address claims concerns. Many of them are doing regular meetings with their key providers. The behavioral health providers specifically are having regular meetings with the plans. I have personally not recently received any communication about significant claims issues. The nature of claims processing is that there will always be some challenges to work through, but we have not received any claims of or concerns of significance recently about widespread claims processing issues. So that seems to be going better. As you mentioned earlier, we've also been working on utilization management and the prior authorization piece. We continue to have conversations in the UMIC meetings surrounding this. When you get down to the fine details of things, there's really some challenges that have to be worked through. Accreditation has certain requirements that we need to make sure the plans are meeting, as we talk about having everyone come into alignment with prior authorization for these behavioral health services that the department has prior authorization policies for. So we will continue that discussion in the UMIC meetings and outside of the UMIC meetings internally. And then credentialing is another significant piece that we have addressed. There was a work group composed of the plans that met to discuss credentialing processes and having that be more uniform. They came up with a form or a spreadsheet that all of the plans will use. There was some provider feedback that Emma is still working on incorporating into that form, but that work group really worked hard to come up with a universal process. So those are the three that I have in mind that we've really kind of tackled over the last few months.
Thank you, Becky. Brent?
Yeah, thanks, Jen, and a nice job introducing this. I think we recognize that many of these discussions will continue on in other settings, and we know that it was the task of this work group to develop recommendations or provide input to us. And I do think these discussions have led to many positive changes and discussions. And I've watched this work group drive the agenda in other meetings that are regularly held within Medicaid or within the behavioral health system. So I think that's been a positive. And I also know that moving from recommendations to action steps are different things. And so we're going to have to take a hard look at the survey results and make some decisions about what to do going forward. But I think ultimately that really was the role of this work group. And so I just wanted to acknowledge that we're not anywhere finished with the work in terms of moving this system forward. And I know that we'll all be gathered in other in other meetings to continue many of these discussions.
Thanks, Brent. Let's take comment from the other attendees here as well. Do you have reflections? Hi, Representative. I think we're trying to cover the milestones really that have been accomplished through this working group and acknowledge the progress that has been made. I think that when we originally convened, there were some clear issues that I think we've made good steps forward on, and there's been a lot of effort put into defining what those issues are and working diligently and collaboratively to make progress forward. So I think that's where we're at now. I'd like to hear what others might want to share as well. Go ahead, Emma.
I always have something to say. Sorry. So I do think, yes, my comment earlier is about this meeting is that we haven't gotten down into the weeds really in this meeting, but we've spun off many good discussions, which I think have been positive. I think one of the things that's frustrating for me is because we haven't gotten down into the weeds in this meeting. We've tried to address issues, but we really haven't tried to really have a discussion about, well, what are the different models that could help the TAM population, and really and flush those out. I mean, we get down to a certain level, and then everyone, and I'll be really candid, everyone sort of runs to their corner, and there are a lot of side conversations that occur, but I'm not feeling like we've had the opportunity to just, and maybe this is phase 2 of this process, right? Is to sit down and say, well, what if it was given to the ACOs, and billing issues are that aside, like you said, Becky, there will always be claims issues. They happen on the medical side all the time, but even just try to just thoughtfully, think through what would this look like, and what would this look like within the context of the justice involved waiver, and really have that discussion rather than everybody having all of their independent discussions, and we don't really get a chance to sit down and talk through all that. And then the other thing I think that I don't want to lose in this discussion is every bit as important as the TAM population is the fact that we still have a really bifurcated service delivery system. So if you're a woman and you are Medicaid expansion today and you are pregnant tomorrow, you get thrown into an entirely different delivery system. And that's not only not good for that Medicaid member, it's confusing for the providers. Because how many times have we heard residential treatment providers say, oh, well, that darn ACO, they're not paying us. And it's like, well, that's because she's pregnant now. And guess what? She's not in an ACO anymore or in an integrated plan. She's with a prepaid mental health plan. So you need to go bill them now for her residential treatment. And it's just so confusing for them. And I don't want to lose track of that because, you know, further integrating mandatory counties is one thing. Bringing TAM on, whether they come into managed care or not, is another thing. But the fact that we have just this bifurcated and have from day one, this system is an issue we don't want to not address at some point.
I agree. Thank you. I think we would all agree there are challenges with our separate systems and navigating those providers, patients, everybody.
And
Yeah.
that's driven by funding, right?
Yep.
I mean, that's driven in large part by the funding streams and the statutory construct that we have and have had for years with regards to who's responsible for behavioral health services in the state of Utah. And I don't mean, I'm not saying I don't know which way it should land. It's just we know it's not straightforward for a lot of people.
Yep, thank you. Anyone else? Hi, Adam.
Hi there. I guess I would just piggyback on that, like with all the stuff that we talked about in here and the UMIC meetings. I mean, at the end of the day, from at least from my perspective as a provider, the more uniformity we can have for any Medicaid member is going to be better. And for us, we have something like 17 or 18 different Medicaid contracts, and that's fine as long as it's all this, like if the rules of engagement are the same, and they're oftentimes not. And I guess that's where like it becomes confusing. And at the end of the day, the client is the one that suffers because they're going from one plan to another, and nobody knows whether they're coming or going. I think the other thing that we've brought up in here, I mean, we had the payment issues and the rate increase issues and all of that, and it's been a really great opportunity for us collectively to have this conversation and bring it to the forefront and actually resolve it, and that has been very helpful. And in the future, my hope is that there's some body like this or something that is ongoing that we can resolve issues when they're pervasive across the whole system, not just one-off provider issues. I guess the last thing I'd say, and I think I've beaten a dead horse so many times with this, but if we really want to make I'm concerned if the only lever for managed care to improve stuff, to improve the plan or improve the plans, the financial performance and all of that is rationing care. I think we've gotten it wrong. And I worry that is the lever that oftentimes insurance companies use to manage the premiums and make sure that they're financially solvent, rather than saying, well, maybe if we did this other thing, it might cost a little bit more now, but it'll save a fortune in the long run and people will be better off for it. And I guess the last thing I'd say with that, if there are going to be changes to how we reauthorize, all of that kind of stuff, that's not happening in a vacuum without a provider perspective. And what that really means to the patient. I get concerned when policies are changed when the people who are making the decisions actually haven't even met a client. So my wish out of all of this is that we have some sort of continued dialogue that if it goes in, if it stays out, if whatever it is, that we are collectively trying to get policies written with the member in mind, and what the implications of that will be. So I'll stop.
Great points. Thank you, Adam. So I'm going to ask just a quick follow-up question, if I could. Sorry, Kyle. If we were going to continue a forum where you have like more broad provider, like broad groups, what would that look like for you? Like, would you not sunset this working group? Is your recommendation to not sunset it, to keep it going and for this purpose, or to have another working group that is like this, but maybe for a more global purpose? maybe not specifically aimed at some of these objectives. What are your thoughts on that?
To me.
Yeah.
Oh, sure.
Since you mentioned it was such a helpful setting and, opportunity to deal with whole system issues.
So I guess it would be, I mean, I think the UMIC meetings are helpful, and we get into more details than we do here. You have maybe less representation from providers, somewhat, but I think there are enough there. I guess what I would be hoping for is that if there are going to be policy changes, that we convene a group like this or UMIC or something like that, that then we have the open forum to say, no, this is a great policy, let's do it. Or have you considered these things before we do that? And really, to the point of doing it in unison with all of the Medicaid plans that are out there.
Yep. Thanks, Adam. Good feedback. Okay. Sorry. Apologies, Kyle. Go ahead.
Oh, you're good. Hey, so I guess my comments, I agree with Adam to some extent that as you look at this, I think we're looking at integration, or we're classifying integration as one way. There is an easy, I mean, you can always go and instead of giving more to the ACO plans, you could certainly go to the PMHPs, and then they don't have, if they switch categories and they don't have that same problem, they can still go to the same provider and stuff. So that, I mean, that can be obviously solved that way too. I also think with the integration, I think you look at it, and I think especially with TAM population, the TAM population is obviously very highly involved in criminal justice and in some of those areas that really, it makes a lot more sense with a PMHP than it does an ACO, because whether it's housing, they provide certain other factors that, that are in play that just aren't done by insurance companies. And I think most would admit to that. I don't know how they mitigate that, but I think they admit to that. So I think Emma's right too, that the devil's in the details a lot of times, and we really haven't gotten to those details. So my thoughts.
Yep. Thank you. And we'll talk about justice here in just a little bit, as it does introduce a new opportunity for us to have these types of discussions that get more into the weeds. Go ahead, Emma.
Yeah, thank you. And sorry for the background noise. I'm having a furnace installed when it's, 30 degrees outside. So it's been great. I guess just a couple of comments. I don't care personally if these discussions continue in the UMIC forum. The way the UMIC meetings are going right now, I don't think they're not quite where Adam has envisioned it. They're not quite at this level. But there's nothing that stops the division from creating your own advisory group like this, on an ongoing basis. It doesn't necessarily have to be stated in legislation. So you could continue something like this, even if this particular, formal group comes to an end. I guess just my other comment is, and Kyle, we have all been talking about this stuff for at least a decade. It's nothing new. But I will also say, yes, I don't know which way this can go, but maybe the ACOs are not the right solution for all of this. I'm not sure the PMHPs are either. I have never seen a PMHP, address a transplant case. I mean, it's like, there is that mix. I don't know what the right mix is, but I'm sure that if we just really focus, like what Adam said, on what is the goal and the member, I think we could get to a place where we could collaboratively come up with something that works. I still think we still need to sort out the funding stream for all of these services before any of this happens, right? I mean, expansion is easy. Expansion's easy because all the money is appropriated to the state, and the state can go about and construct this the way they need to construct it. We know how complicated it is on the legacy side. So I just hope that before I die, we can actually get down to a place where we can come up with, a handful of really well thought out alternatives. And maybe one alternative works well for the Wasatch Front, and an entirely different alternative works well for other parts of the state. But I think that's where we've tried. We've gotten somewhat close in the past, but I think that's really what we need to do, is just say, here's what works for both the behavioral health and medical side or medical needs of these individuals, whether they're expansion or their legacy, what works best in that particular area of the state. And can we appropriately finance it without undoing all the other things that we know, the other sources of funding and the other responsibilities that all the counties have. So I'm hoping we get there.
Yeah, thanks, Emma.
Well said, Emma. I'm hoping before I retire, maybe. I don't know about die, but retire hopefully. So.
I don't want to retire a third time. I'm just, waiting. Now I'm just focused on the end.
All right, Andrew, you're up.
Thanks, Jen. To Adam's point, I was just thinking, and maybe others do, but I don't know what the recommendations are going to look like yet. But I do know the bill is will move forward to create the commission. One of their responsibilities will be to implement the master plan, and I don't know if it does necessarily fit within have a place within the master plan, but I know that at least in the drafts I've seen, integration is one of the things that the master plan talks about. So maybe there is sense in having a line to the extent that the responsibilities of the commission in terms of implementing the master plan are addressed in the legislation. Maybe there is some sense in making sure that this is one of the pieces. If it is not, if the legislation doesn't go to that, doesn't get to that granular level, maybe there is a place for this conversation in one of the multitude of subcommittees or advisory groups that will come through that process, or maybe it should be entirely independent of that. I'm not sure. I just wanted to mention that as another possible avenue that folks could explore.
Thanks, Andrew. Brent, do you want to comment on that?
Yeah, I thanks, Andrew, and I do think, like I said, if the Behavioral Health Crisis Commission is formed, I know that many of these discussions will continue over there. I had another idea, and I'm kind of thinking on the fly. So this could be dangerous, but one of my thoughts is, okay, what do we do with the survey results, and how do we make sure that we all understand what the recommendations are based on your feedback? And having just sat in Medicaid for a while, what I recognize is that all of you are critical partners, but you all have very different perspectives on what should happen going forward. And so we're kind of, as state people, trying to make sure that we're working well with you, that we understand your needs and concerns, resolving them when we can. But sometimes, frankly, even the members of this meeting are at odds. And one of my thoughts, and I look at the structure of this meeting and the survey, and I'm wondering if one idea would be to have the members of this work group who are not part of the Medicaid office meet together once to look at the survey results and see if they couldn't develop consensus recommendations to the department. And I don't know if that's something that you'd be willing to do, but I think sometimes, because we run these calls and because we're establishing the agenda, it changes the nature of the meeting somewhat. And so having the work group come together once without so much involvement from us, to discuss the survey results to see if you could reach a consensus recommendation might be helpful. And I don't know. I throw it out there as an idea, not necessarily a, if it's a bad idea, we can let it go.
Sure, we can take feedback. Thanks, Brent, for soliciting that idea. If others are interested in doing that, we'd be happy to support the opportunity for you to meet, and we can set up a meeting but not attend and have you walk through the recommendations and finalize them as a summary. And that's helpful.
I see people thinking, I don't see anybody.
Sure, we can ask you. I mean, I think by the time we collect the information and share it, you'll have an opportunity to do that if you'd like, and we can facilitate that, or you can do it independently. We can do it either way. So we can put that in part of the dialogue as future items too. So, okay, any other feedback? Okay, so I'm going to move just quickly to next steps. If we could just walk through where we are today and sort of what we're looking for over the next 6 months and even over the next year. And I'm going to incorporate the justice waiver in this. So we know that we're thinking possibly in the next year there could be significant changes that would impact the TAM population, the adult expansion population, with regard to some of the work that's coming forward. It is our commitment as the department to promote integration and continue to work towards integrated model of care. And I think hearing from many of you who spoke today, that's in your interest as well. We may not know the exact solution that we will land on with regard to this, but helping to address some of the bifurcation and some of the challenges that you face as providers, individuals face as members, we face as different stakeholders, certainly is a commitment that we have. What we are doing now, first, I think many of you who are on this call are well aware of the collective work that's been done to really bring the current UMIC contract forward, again, as I mentioned earlier, from payer integration to more clinical integration, and we'll continue in those working sessions and continue to dialogue and move forward with that work. Another piece that I wanted to mention is a question that we've had and that we are dealing with is the UMIC model effective? And I think it's a fair question. Is it achieving its intended results? What do we know so far? Where is it doing well? Maybe where is it maybe not performing so well? It's an interesting question to ask in the context of what we've experienced the last few years. And so I think we all need to understand that there's a lot of challenges that we've had with and disruption and changes in what would be considered normal delivery over the past several years when this model began. Well, 2 months later, we went into a pandemic. And certainly the adult expansion population that's certainly in the UMIC model may not behave as it would outside of those conditions. But recognizing that we still want to evaluate the UMIC model and compare it with perhaps the other adult expansion members who may not be in the model, or evaluate performance within that model alone. And I have mentioned over the last few weeks that we put together sort of a draft analysis of a proposal of what we'd like to look at. We need to invite you into that and are doing that now. We are finishing up our very beginning pieces of a proposal of how we may evaluate effectiveness of this model, and would like to share that with you, both as physical and behavioral health providers and individuals who oversee those systems of care, and also, are invested in this work. What we'd like to do after we have sort of this evaluation designed, we will engage Milliman and have already asked them to conduct the evaluation on behalf of the department. And so what we'll do is we'll define what we'd like to look at, and then hand it off to Milliman so that they can begin their evaluation work. They said it would take them about a month to do this work, at least as a draft, and then they could share that with us. And then, we could finalize it over the weeks following, right? So I'd like to just put that out there as a kind of a next step with the work that we're doing as well, in conjunction with all this other work that's been ongoing. Go ahead, Emma.
Yeah, so I mean, you made the statement that it's not that UMIC, basically the majority of the time, has fallen in the midst of the pandemic, and we can't blame the pandemic for everything, but we do know that people did not utilize services like they normally would have. I mean, I think looking at what's happened in the past couple of years, and then saying we're going to conduct a analysis of the effectiveness of the UMIC plan is a little bit unfair. Because of the circumstances, right? And I think the other reality is even from the get-go, I don't know that we're going to see significant changes in HEDIS data because of that. Normally, what we would see were individual wins, right? For individuals, like what happened for someone who was in a UMIC plan, who had that more seamless, coordination at the point of discharge and had some of their other issues addressed. And I don't think the plans have been asked for those examples for a while, and that's probably because of the pandemic, right? I mean, early on we would say, give us examples of some success stories that you've had, in the UMIC plan. But I think if Milliman, first of all, I don't know who from Milliman's doing this, but Milliman is Milliman, they're just going to look at numbers. They're not going to look at were there individual successes along the way.
I think it's important to incorporate qualitative pieces as well, not just.
I think so, yeah.
And thoroughly describe some of our limitations of the evaluation as well. So I think those should be noted. And certainly if there are qualitative pieces that you feel are important to call out, and those are things that that you can contribute, that should be part of the report. Okay, go ahead, Russ.
Yeah, I appreciate Emma's comments. And yeah, I mean, I think it's true for every segment of the healthcare system, right? That during the pandemic, it's been a different experience. But I think the qualitative pieces are important. I think you recall we implemented a large demonstration project in Weber and Washington counties to work on social determinants of health, working with the local mental health authorities and the federally qualified health centers, and introducing community health workers into the system. And one of the things that we saw that was interesting during the pandemic is while a lot of people disengaged from care, those who were engaged with community health workers in that demonstration project actually remained engaged in their primary care, unlike others who were dropping out of primary care. So I think those types of qualitative pieces are really critical to bring in.
I would agree with that, because I think that's also what can kind of create the foundation of what is the to be. If the numbers aren't there, the foundation is being built to translate to what could be the numbers. Most of the HEDIS data struggled during the pandemic across all populations. So there may be rare pockets where it didn't, but I think we'd see nationally that there were changes, and obviously within our own state, we saw changes within the pandemic. So appreciate that, Russ, as well. And I think noting those different programs that were put in place and the unique ways they were developed and designed to promote care, and what you saw in the midst of that model is an important piece. Thank you. Kyle?
So I appreciate what's being said, but quite honestly, we cannot really think that we can expand this population if we are not doing an actual evaluation of whether it was effective or not. And that anecdotal data is not data. It's the plural of anecdotes is not data. I really think if we're really looking at this, there has to be a very rigorous look at whether this was actually effective or not. And we can't just claim it was effective because now the money is in the same place. I can show a ton of anecdotal data if that's what we want to go with, but I'm a little amazed that this isn't a universal thing, that yes, we want to see that the data does show one way or another. And I get that data is just data and we can make it show whatever we want it to show. But I think there has to be a good evaluation of it that's fair.
Thank you, Kyle. And there will be a good evaluation, which is why we're engaging Milliman and certainly inviting your input on what that evaluation should look like. Okay. So it's important that we have that. So as we design what that is, but there are other pieces I think that are part of this story that may not show in the numbers, but I think are they're relevant, right, to the conversation. But that does not mean that will be absent of the data. The data will definitely be there. And I think Emma's saying the data is not going to show a result, right?
Right. It's
That's
not.
the concern, right?
It's not, and it wouldn't for any population, and that's the point that Russ made. And maybe what the result of this evaluation is, it doesn't show great, on the data. Here are some individual stories, but to be fair, what we should do is recommend another evaluation be done later on after we get through the craziness of unwinding, the pandemic's over, utilization becomes more normal. Then I think if it shows that we have not made improvements, that's a fair assessment, right? At that point to say it wasn't the magic bullet that we all thought it was going to be. The UMIT plans I'm speaking about, but at this point, I just think to just look at numbers and say, well, this is it in a once in 100 year, situation that we had. That's not fair either. I mean, it's, even if the recommendation is, let's come back in another year and do another evaluation and compare that data and see if anything's changed.
Yeah, thank you. And we can't predict what the evaluation will show before it's actually completed, right? So we don't really know, but I do think it serves as a good baseline. I do think since the time we may do the evaluation, like we're building some new things even now that may translate to a different outcome in another year or so. So that's the hope anyway. Go ahead, Russ.
Yeah, I guess what I was going to add to the conversation is just that my hope is that, first we're outlining, or revisiting what were the objectives of UMIC, and then measuring against the objectives. And when I refer to qualitative data, I'm referring to, when I give that example, we actually studied that and quantified data on community health workers, right? So it's not anecdotal, it's actual evaluation that we did. And I think that's, those are other pieces that can be brought in versus pure anecdotal stories.
Thank you. Go ahead, Kyle.
I'll respond one more time, but I agree. I understand that, Russ, and I appreciate that. I just feel like we can't really expect to expand a population that we have not evaluated whether it's effective or not. And so for me, if that's what we want to do, we want to look future because this time frame wasn't appropriate, then that's fine. Let's extend it for another couple of years or whatever, so that we have an appropriate time frame. But I don't see a rationale to expand when there's no reasonable data to show that that's what's the most effective method is. And I don't know what the data is going to say.
Yeah, and Kyle, I guess I'd like to say is that at this point, we don't have like a timeline on expansion. Our hopes are that integration and our efforts to integrate will be fruitful in developing those models, but we don't have a timeline at this point on expansion of the UMIC model, for example, or moving TAM into the UMIC model. I think that's why we're doing the evaluation and continuing to be committed to improve the current state, right? And work from where we are. So And I think that's one piece that I think is worth sharing as well. And it's been shared in other settings this week, but I'll share in this one here is that, this year has been a year for our program, for you as our providers and our partners and stakeholders. And, PRISM has certainly consumed a lot of our time, and it's taken up a lot of our system programming time. And some of the work we may have invested in really being much more focused on this pathway of integration has really gone to, for us and on my team, doing other very large mandated activities for some ways with unwinding, implementing our PRISM system, which we needed to do. And as a result, our path on this conversation maybe didn't go at the pace that we had originally thought it might. But we're continuing forward in this conversation in a commitment to improve the care for Medicaid members, improve the delivery of care, outcomes they experience. And certainly we're going to do that together. So that's really the timeline we're working on. And I just wanted to make sure we were on the same page with that. But that really does move us into what lies before us this year. I think someone might want this room. Are you okay? Okay. Here, in even calendar year 2024, even starting in January, we have a number of positive policy changes that will improve the continuity of care for Medicaid members. When you look at 12 months continuous enrollment for children, 12 months postpartum coverage that goes live, and the non-trad to trad changes that are occurring. Of course, we also know our state CHIP program is coming online. But also with the new year, we are prioritizing with CMS our conversations on our justice waiver. And we are hopeful, as it's now in the governor's budget, our necessary updates that we have to our existing statute that would support this level of care for our justice-involved population in order to align it with CMS requirements. We're hopeful as we move through legislative session that this will move forward with success so that we can actually amend our current waiver and really have productive conversations with CMS for our justice-involved group. So I think those of you who are here on this call, many of you know we've been working internally on this policy for well over 6 months, more like eight to 10 months. We have project leads on this, both from the Medicaid team and from Brent's team that are collaborating on this on a daily and regular basis. We're interfacing with our prison as it's under the DHHS umbrella. We're working with EREP, and we are now beginning to engage external with you starting in the first quarter of the year. So I wanted to share that work is going to be picking up as we believe this will positively move forward in session. If it doesn't, then we will slow down those conversations, but our intent is to move forward with this work. And I think it will directly address a lot of these issues we've talked about with regard to the needs of the TAM population and the specific needs of the justice-involved population to develop a whole system of care that will better support them. A couple things I wanted to mention that have been brought up over the last year and a half is the need for intensive case management. And I still haven't looked at that code, Emma. We talked about this the other day. But one of the things that's wrapped into our request for the building block request that's put forth is a new service that's called intensive care management. And it's going to allow more enhanced care to be delivered and billed for. Not that it's not being delivered today, but we know that it's essential for some of the populations, the TAM population specifically, our justice-involved group. And this is going to be a piece of work that would move forward as part of the package that would it wouldn't be limited to justice, but it would be available as part of our justice work. And then bundled with that as well is our expansion of our existing housing-related support services. So today, those are available for our TAM population, We're looking to expand those to be available to all eligible adult expansion members, and then additionally our justice involved population. And then the next piece of this would be to provide rental assistance for these same populations. So we've got housing related supports, we've got rental assistance and intensive case management services that we're seeing coming through, and hopefully are supported through our session, and we'll be able to bring those online over the next, our goal is to have them online within the year, by the end of the year, and I have them available services. Of course, this is all dependent on CMS, so we know what that's like, but we're hoping CMS is working quickly to help facilitate states that have been doing their groundwork for justice, working on these 1115 waivers for health-related social needs. And this pairing will so beautifully not just address our justice-involved members, but our other members in need as well that are vulnerable and receiving and delivering some of these services, but it will be more coordinated and delivered hopefully in partnership with some of the services that you're coordinating today. So go ahead, Andrew.
Sorry, had to get the mute button. First of all, Jen, this is great news. Thank you so much for sharing it. Just a couple questions as we head into the session, so that we can pretend like we know what we're talking about when we talk to legislators around these issues. And that is, will the housing related services and supports be remain the same as they currently are, just available to more folks, or is there a interest in adding any additional services if possible?
Yes, thanks. Good question. And the request for housing related support services and supports would be to stay the same, but
Okay.
Make it available to more individuals.
All right. And then the second question is, I had heard some rumors and rumblings that that you all might have at least been thinking about submitting an application to be part of the joint work between HUD, ACL, and the other folks on HRSS and the community of practice that they're putting together.
Mm-hmm.
Did you do that, and have you heard anything? And if you hear positively, I'm assuming that what happens there will be part of this work as well.
Yes. So thanks for the question. We did submit an application. We have not heard back on the status of our application yet. But we will certainly work collectively with all the local parties and those here as well, if we were to be able to move forward with that work.
And Jen, can you explain what that is, the application? I'm sorry, I didn't quite catch what that's for.
Yeah, Andrew, it seems like you're pretty knowledgeable. Do you want to share what the combined efforts are here with this and the intent?
I don't.
Yeah.
I'll start, and then you can,
Sure.
and you can fill in and correct me. To my very little understanding of this is to bring together states that either have started down the path of exploring ways to provide housing related services and supports to folks through Medicaid, and I think one of the criteria was to have it approved through a waiver already, and then the community of practice would be to bring those states together and talk about what's working well and what's not, and what can
Okay.
and what are some potential ideas for providing housing related services and supports to different populations or additional HRSS services beyond what some of the states are currently doing. I don't know if I got that close, Jen, or not, but
Yeah,
that
I
was my
actually think you're
understanding.
doing a great job. I think at the end of it, it's to really promote collaboration and sharing. We know that connections between some of these agencies and groups can be our worst enemy, right? And so it's really trying to really build connections, build sharing, and create a forum to do that with some support and facilitation by this. So we're looking forward to it. I'm hopeful we'll get selected, and we certainly have good partners that we've already begun those relationships with here in the state, but we'll enrich those through this opportunity. So nice job.
No,
Thank you.
I appreciate that. And Brian put the link
Yep.
in the chat too. So
Yeah,
that's
I saw
helpful.
that.
Thank you. Okay.
Yep, that's great. So you're welcome to take a look at that. Okay, with that, I think our time is up. I'd love to take any other comments or questions, but yep. Thank you, Russ. We'll grab that. Yes, agree. I had some of those ideas on there as well. We'll pass this around so you can put your thoughts and comments into this document. Greg will pull that and share it with you soon. But in the meantime, what our next steps are here, if there are other comments, we'll take those. But our next steps will be, we're going to reissue a survey to the assigned working group members. Some of you have responded. I know some of you have responded in proxy, or just others have responded because you've contributed to this work, and we're happy to have your responses as well. It is going then to be our work to synthesize what's been submitted into a digestible format for all of our review prior to what will potentially be our last meeting, which would be our next quarterly meeting. And so we look forward to that. Want to thank all of you for your contributions today and for sharing. And certainly, you know, we always want to continue dialoguing about this. So we appreciate your engagement in this. So with that, we'll close this meeting unless there's any other comments. Okay, thanks everyone.
Thank you.
Have a good day.
Bye.
Bye-bye.